Hello, my name is Carrie Hersh. I'm an assistant professor of neurology at the Cleveland Clinic, and I am a staff multiple sclerosis specialist at the Cleveland Clinic Ruvo Center for Brain Health. I would like to thank the organizers for allowing me to present our study entitled Comparative Effectiveness of Switching from Natalizumab to a Moderate versus High-Efficacy DMT in Clinical Practice. These are our disclosures. Natalizumab is a highly efficacious DMT indicated for relapsing forms of MS. In clinical practice, long-term use is limited by potential safety risks, including PML, that can be reduced by switching to an alternative DMT. However, the transition between natalizumab and an alternative DMT poses additional risks since disease reactivation can occur upon natalizumab discontinuation. Currently, consensus is lacking in regards to DMT sequencing following natalizumab discontinuation. Real-world studies are therefore needed to investigate the impact of switching from natalizumab to an alternative DMT on MS disease activity and progression. Observational studies are valuable when comparative RCTs are simply not feasible. Observational studies may also better reflect treatment effects in a real-world clinical setting and answer broader clinically relevant questions. However, observational studies are prone to confounding and bias, and approaches are needed to limit baseline imbalances in disease characteristics before direct comparisons are made. Propensity score analysis is a statistical method that reduces the impact of indication biases by balancing the distributions of covariates across treatment groups, approximating a randomized study design. We sought to fill an important knowledge gap by comparing the impact of switching from natalizumab to a moderate DMT versus a high-efficacy DMT on MS disease activity and progression in a clinical practice cohort, which we defined as the time period of 24 months from natalizumab discontinuation. In the present study, we defined moderate DMT as treatment with either fingolimod or dimethyl fumarate. We defined highly effective therapy as treatment switch to ocrelizumab, rituximab, or alentizumab. We conducted a retrospective observational study of patients with MS followed at the Cleveland Clinic Mellon program who discontinued natalizumab and had follow-up data available. Following IRB approval, all patients who discontinued natalizumab at the Cleveland Clinic were identified. Review of the electronic medical record was conducted to collect baseline data 12 months before natalizumab initiation and 6 months before natalizumab discontinuation. These covariates included clinical, radiographic, laboratory, and patient-reported measures. Analyses were conducted with patients in each cohort at 24-month follow-up, both in a modified intent-to-treat analysis and on treatment. The primary outcome was the annualized relapse rate ratio, measured as moderate DMT versus high-efficacy therapy. Secondary outcomes included proportion with MRI activity, which was a composite measure of new T2 and/or gadolinium-enhancing lesions, proportion with GAD-enhancing lesions and proportion with new T2 lesions, proportion with absence of disease activity, a composite measure defined as absence of clinical relapses and brain MRI activity, proportion with 20% worsening on the timed 25-foot walk and 9-hole peg test as surrogate measures of disease progression, and time to first clinical relapse and GAD-enhancing lesion. These outcome estimates were selected a priori to comment on the durability of treatment effects on inflammatory disease activity and progression in switchers to moderate DMT versus high-efficacy DMT. The PS model was built as a logistic regression to calculate the likelihood of switching to moderate DMT as compared to highly effective DMT using predetermined demographics and baseline disease characteristics. PS weighting was selected due to its ability to achieve optimal covariate balance over other propensity score methodologies, such as one-to-one nearest neighbor matching. In the interest of double robustness, an additional regression adjustment incorporating the linear propensity score was also completed. Following ATT weighting, treatment groups were compared using Poisson regression to measure annualized relapse rate, conditional logistic regression to measure odds ratio point estimates for primary and secondary binary outcomes, and Cox proportional hazards model and Kaplan-Meier survival curves to obtain estimates for survival outcomes. Odds and hazard ratios were calculated as patients who switched to moderate DMT compared to those who switched to high-efficacy DMT. The main outcome was based on a two-tailed test of statistical significance with alpha equals 0.05. Assuming 80% power with a total sample size of 400 patients, the minimum detectable effect size was determined to be 0.26. In the original cohort, 556 patients from the Cleveland Clinic discontinued natalizumab between December 2005 and January 2018. The vast majority of patients discontinued natalizumab due to increased PML risks, averaging 54.9% of the entire sample. In the present study, 270 patients switched to moderate DMT, with 140 switching to fingolimod and 130 switching to dimethyl fumarate, and 130 patients switched to high-efficacy DMT, broken down to 104 switching to ocrelizumab, 18 to rituximab, and 8 to alemtuzumab. More patients who discontinued natalizumab due to PML risk switched to moderate DMT versus high-efficacy therapy. All patients included in this cohort were available for clinical 24-month assessments. Table 1 describes the baseline characteristics of our cohorts. There were no significant differences in baseline demographics between groups. There were also no significant differences in comorbidities other than hyperlipidemia, for which more patients switched to moderate DMT. Vast differences were observed among baseline disease characteristics. Patients who switched from natalizumab to moderate DMT had longer disease duration, were more likely to have a progressive disease course, and more patients who discontinued natalizumab due to PML risk switched to moderate DMT compared to high-efficacy therapy. Washout duration between groups was similar and relatively short to reduce the impact of disease reactivation that would otherwise act as an additional confounder. As expected, based on the higher proportion of natalizumab switchers due to PML risk to the moderate DMT group, patients had higher likelihood of positive JC virus antibody status in this cohort. Further, there were no differences between groups with respect to relapses and brain MRI activity, both at baseline and within 6 months of natalizumab discontinuation. As expected, we can see that baseline disease activity measured via relapses and new T2 and gadolinium-enhancing lesions prior to starting natalizumab was numerically higher compared to disease activity while on natalizumab. There were no differences in baseline objective or patient-reported outcomes measures between treatment groups. The model appropriately assigned higher propensity scores to moderate DMT versus high-efficacy therapy, and there was sizable overlap of propensity scores between the two treatment groups. This confirmed adequate comparability between treatment groups and further confirmed the appropriateness of using propensity score adjustment prior to making conclusions on treatment effect differences between our groups of interest. In our propensity score weighting model, excellent covariate balance was defined as the absolute standardized difference of less than 10% on the means of the covariates across the two therapies, where the green squares represent the pre-weighted measures and the orange circles represent the post-weighted measures. Before propensity score adjustment, the treatment groups were not well balanced, with absolute value of the standardized difference of the linear propensity score comparing moderate DMT to high efficacy therapy of equaling 88.9%. That was considerably over a 50% standard previously proposed by Dr. Rubin. Thus, we favored the need for propensity score adjustment over unadjusted comparisons to account for observed indication bias. ATT weighting effectively balanced treatment groups with only 5 covariates having absolute standardized differences greater than 10% and were just outside of the optimal range. The weighting approach also yielded a similar linear propensity score distribution with a standardized difference of 17.2% that was well within the 50% standard. By 24 months, 13.3% of moderate DMT treated patients experienced a clinical relapse versus 10% of high efficacy therapy treated patients, with an annualized relapse rate adjusted odds ratio of 1.44 that did not reach statistical significance. For all patients with 24-month follow-up and a modified intent to treat analysis, Patients treated with moderate DMT had higher MRI disease activity compared to high-efficacy therapy with an odds ratio of 2.43, GAD-enhancing lesions with an odds ratio of 1.99, and new T2 lesions with an odds ratio of 2.15. In both groups, MRI disease activity fortunately remained low during this time period relative to baseline before natalizumab initiation, though there appeared to be a numerical increase in disease activity relative to the post-natalizumab time point, especially in the moderate DMT group. As a sensitivity analysis, we looked at patients only on treatment with available MRI at 24-month follow-up. In these patients, there was also significant differences in the proportion with MRI disease activity, GAD-enhancing lesions, and new T2 lesions. Patients who switched from natalizumab to moderate DMT had lower likelihood of achieving absence of disease activity equaling 63.7% compared to those who switched to high-efficacy therapy equaling 80.4% with an odds ratio of 0.42. And these patients had available clinical and MRI data by 24 months. Also, natalizumab switchers to moderate DMT versus high-efficacy therapy demonstrated higher odds of disease progression over 24 months, measured via 20% worsening on the timed 25-foot walk and 9-hole peg test. While there was no significant difference in the time to first clinical relapse, Kaplan-Meier survival curves appear to favor patients switching from natalizumab to high-efficacy therapy. Further, switches to moderate DMT experienced earlier time to first GAD-enhancing lesion compared to high-efficacy therapy with a hazard ratio of 6.67. The current study presents the comparative effectiveness of switching from natalizumab to moderate DMT versus high-efficacy therapy over 24 months in a clinical practice cohort. We utilized PS methods to improve the balance of baseline covariates between groups. We believe the variables used in our PS model accurately reflected which baseline health characteristics are considered important in deciding between treatment approaches in clinical practice that could also influence treatment outcomes. Our cohort study showed low disease activity relative to the pre-natalizumab baseline period, though there appeared to be a signal for some disease reactivation following natalizumab discontinuation in both groups. In a PS-adjusted comparative analysis, adjusting for washout duration, these 24-month data corroborated with our early findings at 6-month follow-up. There were no significant differences in relapse rates between patients who switched from moderate DMT to high-efficacy therapy in routine clinical practice. However, patients switching to moderate DMT were at higher risk of early and long-term radiographic activity at 24 months, yielding lower likelihood of absence of disease activity. Further, natalizumab switchers to moderate DMT had higher disability outcome measures, suggesting that patients overall fare better when switching to high-efficacy therapy. We recognize that our investigation is limited and that it is a two-center retrospective observational study design with missing data. Further, our study is limited in our inability to adjust for unmeasured covariates leading to potential hidden bias, and also limited by other biases for which propensity score adjusted methods do not tailor. In order to improve upon the external validity of our findings, we plan to assess the clinical and radiographic endpoints using a large multi-center heterogeneous cohort. This study was conducted with partial support from the Eric and Sheila Sampson Foundation. I would like to thank all of our patients at the Cleveland Clinic for their contribution to this study. I would also like to thank the CMSC for their invitation to present our work in this unique environment during these challenging times. Thank you very much for your attention.